All right, good afternoon, everyone. Again, I'm Gio Medonk out of Cleveland, Ohio. Pleasure to be here. Fantastic program, fantastic turnaround. So thanks for being here with us. So in the next 20 minutes or so, I'll make the case for triple therapy for selected patients. So that's the goal. Here are my disclosures. So we know patients who come to us with metastatic disease are not all the same, right? They're not the same because some are newly diagnosed when they walk in the clinic. You get them a scan, or you got a call from emergency room, and you go get them scans, and you see disease beyond the prostate. That number of patients is going up. It's still considered a minority, although for many reasons on the trials we tend to enroll more of these patients. But that number is rising with the emergence of PSMA PETs. We also have the second group of patients that you all treat, try to cure. Unfortunately, you cannot cure everyone, and they recur. And you get them a scan at some point, and you identify recurrent metastatic disease. So you get two kinds of patients getting to see us, one with newly diagnosed disease or synchronous metastatic disease, and another one with metachronous or recurrent metastatic disease. The other aspect that this figure tries to illustrate is the volume of the disease. We can define it in many different ways. One way has been, and probably the one we've been all quoting, is the data from Charted, right? Defining 4 or more lesions in the bones with 1 outside the spine or pelvis, and or visceral disease, like liver mets, lung mets, as having high volume disease. So high volume, low volume, newly diagnosed or synchronous or metachronous. Why is that important? Well, first of all, because it has prognostic value. You can combine, and you had 4 categories of patients based on volume and based on timing of metastatic disease. Those patients with newly diagnosed high volume disease are destined to do worse. Patients with recurrent low volume disease tend to do better than everybody else. That's really what this data is showing you in terms of median OS, right? So newly diagnosed high volume disease, you can see there the median overall survival measuring less than 4 years, which basically doubles if you're looking at patients with recurrent low volume disease. So it does have prognostic value. Now, we've heard that the addition of ARPI improve outcomes compared to ADT, and I should say, or ADT with first-generation anti-androgen. We're just chatting earlier today that I'm young. I like to think that I'm very young, but I was already around with many of you when we're debating whether or not adding bicalutamide or flutamide to ADT was the right approach. At that time, we were debating survival gains of about 2, 3, 4%, right? Actually, today, we know that ADT with or without first-generation hormones means the same thing. And really, we want to offer a combination treatment, what we call treatment intensification, with a novel androgen receptor pathway inhibitor. With or without chemo, that's what all these data shows you. You control, from the efficacy point of view, you control all the endpoints of interest, including making them live longer. And the delta is huge, is significant, as you can see there. That risk reduction in 30% or more in death, favoring the combination, often translates in more than a year's gain of survival. So the reason why darolutamide is not in that list without chemo is because we have not seen up to recently that data, but we did see that recently. This is the ACKNOWLEDGEMENTS trial. It's actually ex-US study. That was actually presented by Fred Sad, and basically demonstrates that the addition of darolutamide to ADT and placebo is able to significantly prolong time to progression in the scans compared to ADT alone. As you can see there, almost 18–19% difference, absolute difference at 2 years for patients with tumor control. It's not really surprising. We've heard from the efficacy perspective, we know darolutamide to be a very active in ARPI, but it's refreshing to see this. And by the way, I would add, we're going to see data from the US from the ARASEC trial. I think Alicia on that, but Neil Shore and colleagues are basically running that study in the US to basically demonstrate what I think is going to be the addition of that ARPI to the number of options we have without chemotherapy. Now, that's great. It's all trial data. In real life, it doesn't get there quite yet. Half of the patients are still not being offered what we call these combination strategies with an ARPI or chemo. As you can see there, chemo tends to be reserved to about 10% of the patients we see. Half of them are not offered combination strategy. So we got to do better. We have to keep bringing this up. We now have close to a dozen, to 10 patients, to 10 trials or so, showing the same thing over and over and over again. And that's an important message that we should know. So, but I'm here supposedly to talk about triple therapy and whether or not there's a role for chemo plus RPI plus ADT. And that's what I'm going to spend a little bit of time today. Start by looking at CHARTED. At CHARTED, if you recall correctly, it really changed the paradigm, the way we see this. It was actually the first trial we saw conducted in the US, a cooperative group study, kudos to the team who did it, and basically demonstrate that chemo on top of ADT improve outcomes of patients compared to ADT alone. At that time, it was an all-comer study, but the authors, rightful so, knew that chemo might benefit more people than others. And the data at that time suggested that the patients who are destined to the worst are those with a lot more disease, including visual disease or disseminated bone mets. So that's what the volume comes from that trial. What's interesting, you look at the breakdown and you actually see that the benefit of docetaxel at that time appeared to be enriching the patients with high volume disease and synchronous disease. So that story is actually back from 10 years ago, right, 2015, if you will, and then, of course, these breakdown, but we saw that data the first time a long time ago, and how right they were by showing us that. Then we had the stopgap. We just heard the data, that meta-analysis around the AbbVie, which I agree is very provocative, but kind of looking at the same thing, right? Looking at patients with high volume disease seem to benefit the most from chemo, not so for patients with low volume disease. So immediately after we've seen these data, we start talking a lot about treatment selection, patient selection for chemotherapy. But because we didn't have anything else until AbbVie, which was presented 2 years later with STAMPEDE and LATITUDE, we really did a debate about who should be getting ADT docetaxel, who should be getting ADT alone. And then, of course, all the RPIs came, abiraterone first, then enzalutamide and apalutamide came, and before the triplets. And so the debate was, should we do an RPI or should we do docetaxel? And then we had a conversation around triple therapy. But I just wanted to show you where did we come from. So here the pool analysis, the GET2 effort is a cooperative group like inference. So that's the GET2 trials. So basically you kind of see the same thing. You pull all that data together at a time for docetaxel, and clearly you're starting to identify that the group of people will benefit from the addition of chemotherapy, here defined by volume, but not everyone. So with that said, we came up to the question a few years later that, okay, so if ARPIs improve outcomes compared to ADT alone, and if chemo improves outcomes to ADT alone, and the standard of care change from ADT to ADT chemo, also known as docetaxel, what about bringing an ARPI on top of ADT and docetaxel? So you have two trials like that. I'm showing you the Arison's trial, who did that with darolutamide. ADT docetaxel plus minus darolutamide. I think the data is unequivocally positive. You can see the intention to treat population as well as the high volume disease really favoring the triplet therapy versus combo. Now, the devil is in the details. I'll get back to this in a second. But the second effort, it was an European effort from the French group, from Karim, who led those efforts, Karim Fizazi, basically ran the PIS1. PIS1 asked two questions: role of radiation to primary tumor and role of the addition of abiraterone in the standard of care, which evolved at that time in Europe as well from ADT to ADT plus docetaxel. So it turned out to be a question around triple therapy as well. And so what you can see here in the high volume patients that appear, there is a benefit of the triple therapy compared to the doublet, being ADT docetaxel as they changed at that time. So going back to the story, when we look at patients with synchronous disease, meaning newly diagnosed disease, whether you look at PIS1, whether you look at Arison's, or even patients treated with docetaxel and enzalutamide on the ENZAMET trial, you can actually see a benefit of the triplet approach in those patients with newly diagnosed disease. Not overall, but those patients. So you clearly start selecting the timing of metastatic disease and the volume of the disease and some of the clinical criteria we start using to the use of triple therapy. Now, I'm going to stop here for a minute and take you through the biology of this, why this might be the case. Now, this is a beautiful paper or review put together. It's published at the ASCO Educational Book. I invite you all to read it. It's free online. You basically start remembering that we have to know more than just by looking at the patient, look at the scans, and predict what's going on. right? You heard already genetic testing. We're looking for markers. We're looking for what is the molecular makeup of the tumors. Obviously, they're not all the same, right? They're different. Some have aggressive molecular defined, TP53, RB1, PTEN, mismatch repair. We talked about HR this morning, and so on, SPOP. So all that has to play a role. So actually, we do think that we're going to be moving towards a more precision approach where we're going to use these data along with the clinical features to decide what to do. Now, a beautiful way to summarize what I just said so far is actually in a slide put together by Tanya a few years ago when she was debating the data from Enzymet during ASCO. And really, to me, this is how I see the disease. Every time I look at the patient, I think, okay, how much of this tumor is going to be dependent on blocking the androgen signaling pathway, and how much of this tumor has lost the zip code from prostate and is behaving like a poorly differentiated carcinoma. And so if you have those two components, the androgen-dependent, androgen-independent, if you will, it makes a lot of sense for the group of people where we know there's a component that doesn't depend on hormones, we have to address it with chemo. So at least the story makes sense, right? And the schema looks nice too. So getting a deep dive into that, we start looking at patients and the molecular studies that many of us have put together, and we start identifying a group of patients where the story seems to make sense. So for example, this is a cohort, a metastatic hormone sensitive disease there, different cohorts, BRCA, non-BRCA, all HR positive. You can see how it's enriched for newly diagnosed high-volume disease and synchronous disease. So it appears that it's more likely that patients with aggressive presentation are more likely to have characteristics that predict worse outcomes. So the story makes sense there. What also makes sense is actually you find up to 20%, 30% perhaps, those tumors in the hormone-sensitive setting that we know in the CRPC, and we actually call them aggressive variant. When you have alterations in the tumor suppressor genes, like TP53, RB1, PTEN, two out of those three, in the group from Anderson did a fantastic job describing them as AVPC. We actually see that too in the metastatic hormone sensitive setting. And if you look at the characteristics, once again, you are expecting to see a bit more aggressiveness reflected by patients who walk in the clinic with disseminated disease and also high volume like visceral disease. So all the story makes sense there too. And the other part of the story, okay, but what about you look at RNA? What comes out of the nucleus and expresses, right? RNA expression. So we start talking about signatures. For us, maybe we're used more to use the cipher, if you will, but look at the data from Charted on that point. Transcriptome is RNA-seq. We're starting to see that not all patients are the same. In other words, they have different signatures. Some predict response to chemotherapy. Some will say that's not helpful. Right? And when you start looking and matching that with the clinical features, you again see the story making all the sense. So going back to the clinical data, there's at least a few meta-analyses out there that basically are looking at, okay, can we please compare then ADT-ARPI with ADT-ARPI docetaxel? Because we don't know that, right? We know ADT-ARPI docetaxel is better than ADT chemo, but we don't know about whether or not the RPI ADT better or not than ADT RPI docetaxel. So the meta-analysis is trying to do that. Some is tough because you got to get the data, individual data from all the trials is not always possible. However, when you start looking at that, for patients with high volume disease, it appears the signal favoring patients treated with triple therapy, which once again makes the case that for some patients covering the two portions of the tumor, dependent on androgen, the other one independent of it, makes a lot of sense. And when you look at that, it is, by the way, is a live meta-analysis, beautiful work from the Mayo group, Irbaz. Here you can see actually when you rank by the power of the signal in controlling the disease, rank 1, Daro, Dosi, ADT, rank 2, Abi, Dosi, ADT, ahead of the ADT RPIs. Again, we're looking specifically at those patients where you would predict they actually need more treatment. So all of this is conversation, but the question is always, what do you do tomorrow, right? What are you going to do in clinical practice? How do you put all this together? So this is kind of what I have in my mind every time I see a patient with metastatic hormone sensitive, right? First step, castration. Second step, RPI. Third step, chemo. So how do I do this? Well, first, we treat people because we want them to live better, and we also want them to live longer, right? For the vast majority of the patients, that means lowering testosterone levels. That means castration. Not 100%. We treat around 80% of people we see with metastatic disease. Remember, we have to include those patients who are very sick at the hospital, admitted, several comorbidities. They never get to see us and make it to an outpatient setting. But for those who do, the vast majority actually get castration. Then every time I answer the question, is the life expectancy of the patient in front of me impacted by prostate cancer? I'll absolutely do a combination treatment. And of course, I always take into consideration things like comorbidities or drug-drug interactions, et cetera. And my final question is this a patient where I should be thinking of more, right? What do I mean by more is like triple therapy. Do I need to bring docetaxel into the equation? Absolutely, their life needs to be impacted by metastatic prostate cancer. Also, I need to think of the timing, synchronous versus metachronous, the volume, as I said before, as well as can he actually get chemo? Is it safe to do it? As well as molecular features. So with that, I would say that I tend to offer triple therapy for those patients with newly diagnosed disease, where survival is impacted by their metastatic prostate cancer, and patients with a lot of disease, a lot of bone mets, liver mets, where I do have a bias because that behavior tends to be associated with that less androgen-dependent disease, if you will. And finally, of course, patients need to be fit for chemo. Now, I'm going to make a comment about this. This doesn't need to happen on day one. We do what I call really a multi-step approach, going back to my old slide, where I actually see the patients, I introduce the concept of systemic therapy and castration, I explain why the importance of genetic testing, and once I do that, I explain what castration means. Patients come back 3-4 weeks later, and I then introduce the concept of ARPI. So when I introduce the concept of ARPI, I might or might not have the results from genetic testing, but once again, they can go home and they go on ARPI and then come back 3 or 4 weeks later. And at that moment in time, I will be better equipped to decide whether or not it's a patient for triple therapy. And I have both cases. I have some patients where I'm convinced from the get-go I'm going to do triplet, and for whatever reason, 8 weeks later, 9 weeks later, I might not do that because I don't think it's safe, and vice versa. Patient might be so symptomatic, but as soon as I start with EDT RPI, when I come back 8 or 9 weeks later after being on RPI EDT, I was like, well, patient recover a lot, because this patient is going to respond, the vast majority of them, and that's when I bring docetaxel. So that multi-step approach, it's a lot, but allows you to break down the information as you share it to your patients in clinical practice. Now, just to make it slightly more complicated, the story is not over, it's going to continue to change. These are just some of the efforts. I'm hoping let me show you the slide. It's not moving. Can we move to the next slide? No, there you go. Okay. So I think the story will going to continue to get even more complicated. These are some of the trials that are going to read out soon. I can tell you we'll see data from Amplitude very soon. That's with a PARP inhibitor. So we'll see what happens there. We already know that patients with PTEN deficient, the trial is positive. There's a press release out there. We have not seen that data, but we might have to be introduced to the use of capivasertib, which is a therapy in the context of the biomarker selected population. And what about lutetium, radioligand therapy in hormone-sensitive disease? We don't know what's going to happen there, but it's possible that we'll move to this setting as well as other PARPs like talazoparib. So we're really getting a lot of pressure to understand who gets what, right? So in my practice, I no longer do ADT and chemo alone, because if I'm going to do ADT docetaxel, I'm going to do a triple therapy, right? But it's still not evident if the doublet with an RPI is inferior or similar to a triple therapy with RPI and docetaxel. To address this specific point, we actually have 2 trials that I want to highlight as 2 of my last slides. One is this adaptive approach. How about, instead of us doing triple therapy to everybody, we actually start everyone on ADT RPI, and then depending on how they do, we will bring docetaxel on board. So it's an adaptive design. It's like a multi-step approach that I defined to you, that I described, but instead of doing it at 9 or 10 weeks, you might do it at 6 months or 9 months. Based on what? On this effort from Canada and SWOG, this is based on PSA response, specifically undetectable PSA. Why? It appears to be the earlier signal of outcomes for patients with metastatic hormone-sensitive disease. You want to have your patient to a PSA of less than 0.2. So that's being used to decide who goes on this study. Patients who don't achieve undetectable PSA or PSA less than 0.2 are randomized to docetaxel or continue on the same ADT-ARPI. So that's the first of the two studies I'm going to show you. This is the second. It's called ASPIRE, which is really trying to answer the question I just raised. So we know that ADT chemo is inferior to ADT chemo RPI, but what we don't know is whether or not ADT RPI is equivalent to ADT RPI docetaxel. So here's the trial that's going to try and answer that question. It's called ASPIRE, it's also Alliance. So kudos to the cooperative group studies because they're really trying to change and help us to understand more this setting. With that, here's my last slide. I hope I made the case, continue to make the case. The combination therapy with an RPI, it is indeed standard of care for patients with metastatic hormone-sensitive disease. Triple therapy has a role in high volume, synchronous metastatic disease, and for patients who obviously are fit for chemo. We don't have comparison data for doublets with RPIs versus triplets. I hope I made the case for molecular characterization is likely going to be included in the future, the way we're going to be treating these patients, as well as novel therapies that we have to learn how to use them. And finally, I think future might include other triplets, I think it will, and also will include probably adaptive designs. I have not mentioned anything about treatment de-escalation. I'm going to leave that for the discussion perhaps, but that's also something else that we need to be mindful of. Some patients might be well treated with de-escalation, but because I was trying to focus on chemo intensification, I didn't bring that up. With that, again, it's a pleasure to be here with this group. Fantastic panel, fantastic group. Happy, we're going to be all around all day, so I hope you find this talk and this course helpful. Thank you so much.